coming up.
So what the things that Rachel and I have coordinated what we're going to talk about. We're going to talk a little bit about the UW-ACTU and COVID-19, and at least from my perspective, answer Michael's question, but obviously other people can chime in. We're going to talk a little bit about the epidemiology of COVID-19, which helps explain why we are going to be doing research. We're going to talk about the current data, or really the lack of current data about treatments for COVID-19. And then we're going to briefly describe 3 studies that the UW-ACTU will be involved in. None of them are going on right now, so we are in an educational mode about these studies. We are not in a recruitment mode. So let's you do the next slide? Great.
You got it.
So, as hopefully most people who are alive today know, there is a new illness caused by a previously unknown virus that is a member of the beta coronavirus family. And the virus itself is called SARS-CoV-2, and that comes from, it's a coronavirus, which are a group of viruses that have been around for a while. There are many, many coronaviruses that have been identified previously. They, for the most part, are a cause of upper respiratory tract infections or colds. There are 2 that have been notorious in the last 15, 20 years for causing outbreaks of serious illness. The first of those was known as SARS, standing for Severe Acute Respiratory Syndrome. And then the second of those was called MERS, which was Middle East Respiratory Syndrome. And then this latest one that appeared to emerge in Wuhan, China, in the very end of 2019, which is where the 19 comes from, the virus itself has been named SARS-CoV-2. And the disease that SARS-CoV-2 causes has been called COVID-19. And while there's a lot of debate about where it came from and where it started, and what is very clear is that it rapidly spread across the globe, that different locations have used different strategies to fight the transmission of this epidemic to others, including hand washing, social distancing, stay-at-home orders, and this, what is now called a pandemic, meaning an epidemic that has spread across at least 3 continents, have resulted in major changes in society, including in ongoing research across the globe, including at the University of Washington and at the UW AIDS Clinical Trials Group. Next slide. So, in response to this epidemic, both our local administrators, namely at the University of Washington, the research program that the University of Washington has, and the AIDS Clinical Trials Group, which is the international research group that we are members of, develop policies to help react to COVID-19. And those policies included having people work from home if that was possible, halting enrollment in ongoing studies that we were doing, and a change in the strategy for visits for ongoing studies, namely all but essential in-person visits for safety monitoring were prohibited in line with the stay-at-home orders that were part of our institution. And for when in-person visits weren't essential, it was strongly recommended that we do visits by phone. there's one study in particular that we're going on that is providing antiretroviral therapy to its participants, and we made a strategy to make sure that people would have continued supply of those medicines. For the most part, they get mailed. Occasionally, if people are coming in for a visit for some other clinical reason, or to see us, and that happens to coincide with when they need medicine, then they get their medicine from us in person. And as a result, because of this slowdown in research, it meant that our unit, as well as the AIDS clinical trials units across the globe, had capacity to do something else. And because this is a treatment research network with expertise in doing infectious diseases research, it was pretty logical that the NIH would ask this network, as well as some of its other networks, to do research on COVID-19. And so that's what I mean by repurposing, giving the AIDS clinical trials group and its sites a new purpose, in addition to the ongoing HIV work, which has continued to be ongoing, both in the studies that are underway at the present, although they have been modified, and in the planning of new studies, which is also continuing. And in fact, the head of the ACTG made that point in a Zoom meeting that we had just last week, encouraging people to continue to submit concept proposals and continue protocol development for new ideas. So even though the network and we are going to be doing COVID studies, that doesn't mean that HIV research is stopping or won't be continuing. Next slide. So now I am handing things over to Rachel, who's going to talk a little bit about just the timeline of COVID-19 to set the stage for our discussions.
Okay. Thank you, Anne. So my plan is to be relatively brief with this because I showed these two slides last month when we met. I'm mostly showing them to sort of give context for how far we've really come since the last time we got together. Michael, do you mind actually just moving back into that last one?
Yeah, I don't know what happened there.
Somehow all those...
They just kept going, so here.
Okay, yeah, sometimes the automations... Oh, I wonder if it's timed.
It might be timed, yeah, so I'll try to stop it.
Okay, that's weird. They didn't do that last time.
Yeah.
Okay, in any case, so the new news since our last meeting is that we've now found out that the first deaths in the United States don't seem to have been in Washington. That it sticks out here on the timeline that we now know of 2 deaths that occurred in early February that may have been due to people that traveled, but these people were not directly linked. So that changes sort of what we know of the epidemiology a little bit. Also, on the 23rd of March, so that was the day before we last met, the global count on cases was 341,000, and now we are well upwards.
Sorry.
Oh dear.
God. I know how to fix this, but it requires coming completely out of...
Okay.
I was going to say, we're going to have to turn it off.
I'm going to turn it off. Yeah, I got it. Let's see. It's the timings here, right? Slideshow.
It's in...
The review.
Yeah, so unclick the timings.
Yep.
That should work.
All right. Sorry about that, everyone. And we're going to take it from there.
Okay, hopefully that should work. Okay.
So where did you want me to go in your timeline?
I think into the graph of the U.S. after this one is fine. Okay, so so just to show that in the month since we last had a CAB meeting, it went from something like 300,000 cases worldwide to now over 1 million cases in just the United States alone.
You wanted me to go?
So pretty striking difference. Go ahead and advance, please, Michael.
There we go.
Yeah,
Yep.
there we go.
Yeah.
So perfect. Okay, so this is just the U.S. and this is the cumulative number of cases, just showing the top 10 jurisdictions in the United States. If you're squinting at these lines, you'll notice that Washington does not even appear on them anymore. So the time that we last spoke, is it still advancing on its own?
No, I think that was my finger. There you go.
Okay. The time that we last met, Washington and New York State, I believe, both had about 200 cases. New York has had a tremendous number of cases since then. I believe they're at over 100,000 cases in New York State alone. And Washington no longer is the top 10 states in cumulative incidence. And, you know, I think we, well, I guess go ahead and advance to the next slide.
Sure.
We have had a total of 13,000 cases as of Sunday and 738 deaths, as compared to New York is seeing this number of deaths per day in some cases.
Wow.
Go ahead and advance. And this is just two pictures of what we call our epidemic curve. So this is the number of confirmed cases in blue per day and deaths per day. So it's pretty easy to see that we have peaked here in Washington State now, both in cases and in deaths, with deaths lagging behind cases because they tend to occur after someone has been ill for several weeks.
Oh, it looks like it looks like something didn't get turned off, or something got turned on.
Oh, I would turn off the play narrations. I would turn off the play narrations as well. Let's see if that works.
Let's try that. Did you want to go to this slide?
Sure. Oh, maybe back one more. So just yeah. So I think that this is really, you know, confirming the fact that the stay-at-home orders in Washington have been working, that we avoided the epidemic that many other states are now still continuing to have, although obviously 13,000 confirmed cases and 738 deaths is important. Each of those is a person. And recognizing that the case count probably exceeds the number of recorded cases by probably 12 to 20 times, meaning that we're only documenting the number of cases of people who actually can get a swab and who swab test positive. And we think that the true number of infections is somewhere right now between 12 and 20 times higher by the best modeling estimates. We may also be underreporting deaths because people who were not tested and died due to COVID are not counted in that. And then additionally, people who, for example, died from another cause and because they didn't receive care or maybe were sheltering in place rather than seeking care are sort of added to the total of the impact, the health impact of this epidemic that's really being undercounted. And we think that in areas like New York City, where the health system is very much overrun, that the number of true deaths due to COVID is probably twice what's being reported, both due to cases that are not being counted and people who, for example, had heart disease or a stroke and chose not to go to the hospital because they were worried about seeking health care. So go ahead and advance.
Okay, so I am going to pick up, now that we've heard that news, and talk just very briefly about the clinical course of COVID, which sets the stage for the treatment and the structure of these studies and who will be sought to enroll in them. So I think people may be very well aware that there is a extremely variable clinical course for COVID-19 that we really don't understand. And Rachel alluded to the fact that there are likely to be people who have had this infection that did not recognize they had it, and even if they recognized it, may not have been able to get tested. The best estimates that we have are that about 80% of the people who present to medical care have mild to moderate self-limited illness, with the symptoms of fever, cough, and shortness of breath being the most common, but by no means the only symptoms. And other symptoms that have been well documented in people who have documented COVID include fatigue, muscle aches, sputum production, headache, dizziness, diarrhea, nausea, and vomiting, and then hearing and smell changes. Maybe taste changes, but there's a little less documentation of that. And taste and smell go very closely together. It appears that about 15% of people who come to medical attention will develop moderate symptoms and about 5% of people may develop critical illness. Next slide, please. And that critical illness, so the severe and critical illness generally manifests as a pneumonia, which can progress to what is called acute respiratory distress syndrome. The term syndrome means that we don't really understand the cause of something. And this term ARDS can be caused by lots of things, but it is clearly known that viral pneumonia is one of the causes of ARDS, and that many people with COVID-19 who present and develop very severe illness get this ARDS. Other problems that have been described include kidney problems, including kidney failure, with a need for some kind of renal replacement treatment, which can take many forms. Dialysis is one of them that you may have heard of. Blood clotting problems, with people developing blood clots in places that they shouldn't. Heart issues, and a whole host of other complications that have been described, although don't appear to be as common as the ones that I've listed here. And then, sadly, as you've heard, people can get so ill that even with excellent supportive care, they may die. Next slide. The laboratory findings that have been described in people who have COVID-19 include having low levels of lymphocytes, so lymphocytes being a particular kind of white blood cell, and it appears to be across the board lymphocytes, not just the CD4 lymphocytes that we know are linked to HIV. They're also, in most people, especially if they get critically ill, is an increase in levels of the markers of inflammation. The most common of those that's measured in the clinical setting is something called C-reactive protein, but there are a variety of other markers of inflammation. There often is an increase in levels of markers of blood clotting, which is a test that in the clinical situation is often used to measure something called D-dimer. And the markers of systemic inflammation, at higher levels being more abnormal, tend to be associated with more severe COVID-19 illness. And there is some similarity in this to a condition that is called cytokine storm that has been recognized to occur in other medical conditions, which is basically when the body system goes haywire with it producing lots of these markers of systemic inflammation, which themselves can do damage. And the term cytokine just is a term for chemical messengers. That certain cells in the body produce certain chemical messengers, and cytokine are just the overall name for that. By the way, anybody is more than welcome to interrupt me anytime to ask any questions. And this is sort of a complicated slide, and I was trying to find a slide. I was trying to find slides for this because I hate talks that are just words, but there aren't a whole lot of slides that I found that were that useful in terms of my talk. So what I want you to do is focus on the right-hand side. We believe that the SARS-CoV-2 virus first infects epithelial cells, and those include epithelial cells in the lung. And that is one of the reasons that some people develop pneumonia. That is not the only place that this virus, that lung cells are not the only place in the body that have the receptor on their surface that this virus can attach to. And then it appears that the body reacts to this by producing cytokines or chemical messengers and chemokines, which are specialized kinds of cytokines that then communicate and result in immune cell activation. So there's this inflammatory acute inflammation that occurs. And then for reasons that we really don't understand well now, people either go on to resolve their disease and their bodies are able to recover from this acute inflammation and turn it off, or they can't and they go on to very much more severe disease and this cytokine storm and multiple consequences of that severe inflammation, which can further damage the lung or the kidneys or other organs, and then lead someone to need to be hospitalized for a prolonged period of time, which then leaves them susceptible to getting other infections, because when you need life support with a ventilator and a tube down your throat, or need IVs or prolonged other kinds of treatments, that can leave someone susceptible to getting other infections. Next slide. So with respect to the treatment that we mainly have for COVID-19 and its complications right now are symptomatic treatment and supportive treatment. So there is no FDA approved drug that has been shown to be effective at treating this virus or the consequences of this virus. But there has been an absolute media frenzy with medical literature that is in this, what is called preprint. And so there are websites that exist to collect and publish medical research studies before journals have accepted them or reviewed them. And so in the medical literature, when something has, in general, prior to publication, anybody who wants to publish something submits it generally to a journal, who then will have it reviewed, meaning evaluated by experts in that area to determine its quality, make suggestions about improving it. So the peer review process, which has its issues, but in general tends to improve the quality of what is published. So in the COVID era, there are these websites that print,
Sorry.
No, that's all right, not your fault. Print and publish journals articles before they have been peer reviewed. And those are called preprints. And unfortunately, at least unfortunately from my point of view, people who do not critically understand how to review an article may take the message from these pre-printed research results and go crazy and assume that if a preprint says something is useful, that it is useful, or that it's been shown to be effective or too toxic or something like that. And the reality is that is not always the case. That what makes it into the formal medical literature usually is better than it was when it was submitted. But unfortunately, even some really good journals have published some things that are a little suspect or not very strong in terms of their justification for the conclusions. But what is clear is that the number of people and how broad a swath across the globe COVID-19 has occurred has created an intense search for effective treatments. And there is this federally sponsored website called clinicaltrials.gov that is just in the US. If you have government-sponsored research, you need to make your plan widely available on a public website, and clinicaltrials.gov exists for that purpose. And just the other day, there were 908 human studies for COVID-19 treatments listed on this website, suggesting that if we had looked 3 or 4 months ago, there would have been 0. And so just an enormous outpouring of energy to try and develop treatments. So there are lots of treatment approaches that you have heard about. I'm going to just briefly talk about a couple of the antiviral treatments. There are other studies of host modifiers and immunotherapy, and Rachel's going to talk about one of those with an eye to trying to dampen the cytokine storm. There are adjunctive treatments, there are anti-blood clotting, there are critical care optimization things going on. And then there are disinfectants, which a very famous American either said or was misunderstood to have said, depending on your point of view of what this individual said. But the bottom line is don't drink or inhale or inject bleach, because that is not going to help someone who has COVID-19. And it would be really bad for someone's health. Because the reality is, just like HIV, you need targeted antivirals that have to impair the replication of this virus without doing damage to the host. And bleach would do a lot of damage to proteins and genetic material and someone, and could easily be fatal. Next slide. So remdesivir is one of the antivirals that there has been the most discussion about, and we're not going to, another is lopinavir, the combination of lopinavir and ritonavir, or Kaletra, which is an antiretroviral previously used for treatment of HIV and actually in many settings still used. And Rachel discussed that last month, so I'm not going to talk about that. And then I'm going to talk a little bit more about chloroquine and hydroxychloroquine. Next slide. Any questions, anybody? I'm getting tired of talking. Hope somebody has something to ask me soon. So remdesivir is inhibits the RNA polymerase of SARS-CoV-2.
There are chats, Michael.
Excuse me?
There are chats.
Oh, there are chats. Oh, Michael, can you?
I can't see the chats. Chris.
Oh, I actually already handled the chats that I saw.
Oh, okay.
So,
Okay. Are there important ones that I should stop and we should discuss, or were they all things that you felt like weren't of great importance to the rest of the group?
I think a couple people were asking for definitions of things, and I replied all, so people are free to read the definitions.
Robert has a question. Robert, if you want to unmute yourself, you could ask your question.
Sorry, there we go. Yes, wondering how these treatments, remdesivir, lopinavir, ritonavir, other virivirs, how they would affect an HIV-positive person's current antiretroviral therapy.
Okay, so that's a really excellent question. So lopinavir, ritonavir was used as an antiviral and is in less common use now because it was associated with a substantial amount of side effects, and the ritonavir part had a lot of drug-drug interactions, specific with a specific long list of drugs. If someone had HIV and is successfully suppressed, then use of lopinavir or ritonavir would only have an impact if they were on another drug that was likely to be affected by the ritonavir. So it would be like layering on another antiviral on top of a successful regimen. So it probably wouldn't impact negatively on their ability to remain suppressed. But depending on, for the most part, what other medicines they were on, it might have an impact. And if someone was receiving a regimen that included cobicistat, which is a booster that is used to boost elvitegravir, for example, or sometimes some other protease inhibitors, the ritonavir that is used with lopinavir is used for that exact purpose. So it might have an adverse impact by boosting the level of the drugs they were on. So as with any treatment, I would strongly urge that someone considering adding something to their regimen be sure that they discuss that with someone who would know whether there's a problem or not. Hopefully the person's medical care provider.
Well, quick follow-up on that. So these two medications, total of 3 medications, could be added. Let's say someone HIV positive, gets COVID-19, and I'm sure that's happened.
It has happened. I am well aware it has happened. It has happened to people I know, so yes.
Okay, so if any one of the combination of these medications were added to their existing combination therapy, unless it's contraindicated that we know, and I'm just throwing out Crixavan because it popped in my head, but if they know that, oh, you cannot take lopinavir with Crixavan because we know empirically this is going to happen, you just can't do it. Are these 3 other medications anywhere linked to complications that long-term survivors have, heart medications, kidney medications,
Okay.
liver medications?
Okay, so the ritonavir of lopinavir and ritonavir is a sort of prototype medicine for drug-drug interactions because that's how it works. It works to boost other medicines by interfering with their metabolism. There are known interactions between remdesivir and some other drugs and hydroxychloroquine and some other drugs, and I'll go on to talk about those. But not in the same way that ritonavir does. So that there clearly are medicines that we would want someone to either not be on, or depending on the medicine, if it was safe to stop while they were taking some of these agents. But one of the things is you have to say, how long is someone going to be taking the medicine and how long is it going to last in their system even after they stop taking it? Because there may be drug interactions that are not good, but if someone only needs it for a very short time period, then they might be able to stop something, take this, start something. Or if these are even shown to be effective, which at the moment we don't know, it may turn out that something that is effective doesn't have the set of drug-drug interactions that would be a problem with certain HIV medicines.
Okay, so that's perfect, because just to say we don't know yet is a good enough answer for me.
Well, we don't know yet, which is why we want to do research.
Yeah, you got it. But it does give some clarity as to if I present and I'm in Cleveland, I go to Cleveland Clinic. Personally, from personal experience, with ritonavir. It is a booster. It does what it's supposed to do. But my personal experience with it has not been the best outcome, let's say.
Well, you and a lot of people, which is why, why we tend not to use much ritonavir any longer. One of the beauties about doing research is that it helps improve care over time. And so there are many drugs that used to be used for HIV that are no longer in common use because they have been superseded by drugs that are either less toxic or more effective. And so it's kind of interesting as someone who did prescribe a fair amount of lopinavir and ritonavir a long time ago to see it repurposed and being studied for COVID-19. But on the other hand, if you have very serious illness and if it happened to work, then you have to trade off maybe some bad side effects for a short term for some other gain. Turns out with lopinavir, ritonavir, that it may not work, at least in seriously ill people. It doesn't appear to work.
Okay.
So the remdesivir is an antiviral that, for those of you who are familiar with RNA polymerases from HIV, it inhibits the RNA polymerase of SARS-CoV-2, has no effect on HIV RNA polymerases. It is active in the test tube against SARS-CoV-2 and in a monkey model. And there have been a number of small human studies, including a recent data leak from a small clinical trial that was apparently published for a few hours when it wasn't supposed to be. But there is really no definitive data currently that says that remdesivir is effective or not. Even the esteemed New England Journal article, which published information from the compassionate use program, wasn't very helpful in terms of really showing that it worked. It showed the toxicity profile, but it was really very difficult when you show just patients are treated and here's what happened to know whether that was effective, whether it really helped people. There is an ongoing randomized NIH-sponsored clinical trial in hospitalized patients with COVID-19 who need oxygen support that is comparing remdesivir to a placebo, and it is anticipated that that study will have some results within a few months. Gilead makes remdesivir, so for those of you who are familiar with Gilead, it's the same company. They have had a compassionate use program that they are now changing into an expanded access program that will have more widespread availability than their compassionate use program. For those who are not able, for whatever reason, to participate in the clinical trials, either they're not eligible or they're at an institution that doesn't have access to the clinical trials, which is the majority of the United States, actually. Next slide. So chloroquine is a medication that is FDA approved for malaria treatment and prevention and autoimmune disease treatment. And it also has been shown to have antiviral activity against SARS-CoV-2 and is thought to have activity by increasing the pH, so making less acid in lysosomes, which are basically a structure inside cells. And that interferes with SARS-CoV-2 and prevents it from fusing with cells and getting into cells. And there has been a media frenzy about chloroquine for a variety of reasons, including, but in the last, so that was like 2 weeks ago, media frenzy, 3 weeks ago, huge frenzy. But in the last week or so, there has been more concern about potential cardiac toxicities, with a couple deaths reported in a very preliminary report of patients that were treated in Brazil with very high dose chloroquine. It was a randomized open label study of high dose versus low dose chloroquine. Most of the patients in that study also got azithromycin, which is an antibiotic, and a flu drug called oseltamivir, making it very hard to tease out what exactly was responsible for the cardiac toxicities. And this drug does also have anti-inflammatory properties. Next slide. So that leads us to hydroxychloroquine, which is a derivative of chloroquine that is thought to have substantially less toxicity. It is also approved for malaria and autoimmune diseases, has an anti-inflammatory effect on rheumatoid arthritis and lupus. It also works by the same mechanism as chloroquine. And there was a very great media frenzy after preliminary reports of a preprint from France and endorsement by a prominent US politician about the effect of this. The preliminary report was a preprint of a relatively small uncontrolled study of patients, some of whom were treated with hydroxychloroquine, 6 of whom also got azithromycin, not erythromycin, azithromycin. And the comparative group were not even at the same institution. Hydroxychloroquine has been made available from the federal stockpile of drugs under what's called an emergency use authorization. And this is not the same as FDA approval. It just says that if drug is given to inpatients who have COVID from this federal stockpile, if something bad happens, the institution who gives them the drug and the physician who gives them can't be sued. But it is by no means the same as saying this is safe or effective. And there are also concerns about potential toxicity with QT prolongation, QT being referring to changes on tests called an EKG or an electrocardiogram, which records electrical activity of the heart, and QT is the way that those electrical signals are visualized on. And there are arrhythmias, which mean interruption in the heart rhythm, especially with long-term use. But most of the toxicity of hydroxychloroquine has been in people who've been on it for months or years. Next slide. So this, I just want you to, is another picture. And it just is showing that chloroquine and hydroxychloroquine are thought to interfere. They do interfere with viral replication, but they also interfere at the level of the cytokine cascade. And so the mechanism by which they are able to inhibit SARS-CoV-2 is both early in viral replication at this fusion point as well as later so there are 2 places that they are thought to interfere with the pathogenesis of SARS-CoV-2. So pathogenesis meaning how SARS-CoV-2 causes disease. Next slide. And if there are other chats, I can't see the chat, so I can see if there are questions that you think everybody would benefit from. Chris, please let us know, or Rachel.
I'm trying to answer them as we go, and I'm responding all so that people can all see the responses. If anybody is not reading chats or wants something different, let me know, but I'm trying to keep up with them so that Anne can keep talking too. Okay,
well, thank you. I appreciate it, because I'm not looking at the chat box. I'm looking at my slide. So the rationale for combining hydroxychloroquine with azithromycin. So my first bullet is not a rationale. I put FYI is just to let people know that azithromycin, in case you haven't heard of it, is an antibiotic that has been FDA approved. It's widely used for a variety of respiratory infections. So the rationale for its combination with hydroxychloroquine includes the fact that the class of antibiotics that azithromycin is part of, called macrolides, accumulates in certain specific types of white blood cells and macrophages, and it gets very high levels in those. And it also increases the pH in these lysosomes of those kinds of white blood cells. It also has been documented to have inhibitory effects on inflammation in the lung. And what has been shown is that the levels of antibiotics in these cells are associated with the inhibition of a chemical messenger called interleukin 6, which is part of this cytokine storm that I mentioned. And in a lot of other situations, other inflammatory diseases that include both acute and chronic lung diseases, azithromycin has been shown to have immunomodulatory effects, in addition to the antibacterial effects. So the antibacterial effects have no are unrelated for why this compound is being studied for its effect in COVID-19. Completely. So I'm going to stop there, but I am going to say that azithromycin might be used for secondary infections. So if somebody was in the hospital for a long time, they might get, especially if they had pneumonia, especially if they were on a ventilator, which is a breathing support, they might get infections. They often might get treated with antibiotics, but azithromycin would not be a common antibiotic to be used in that circumstance. But it is really not at all clear from the initial reports from China when people got azithromycin why they got it. But this now infamous paper from France had this figure, which got a lot of people's attention. So this is a preprint, but it's a figure that looks over time from the first day that someone had a swab of their nasopharynx, so at the very back of the nose, where the nose joins the throat, which is called the pharynx. And that's how we generally test whether someone has an active COVID infection. So it looks at the proportion of people who had positive samples. So you can see on day 0 at the left-hand side of this graph that everybody, because that's how they were diagnosed. And then over the 6 days of this study, that the individuals who got chloroquine in the blue had a gradual decrease in their SARS-CoV-2 PCR positivity, whereas those who did not, slightly less over time, but not as dramatic as the hydroxychloroquine, and not nearly as dramatic as the subset who were also given azithromycin. And the people who got azithromycin, it's not at all clear from this report why they got azithromycin. So this is what generated all the hoopla and interest in hydroxychloroquine and azithromycin. So pretty dramatic, if it's true.
So there's questions about this. This is a preprint.
So it's now published. It's now published in the International Journal of Antimicrobial Agents.
Okay.
And there was a follow-up study that was larger, that was also by this author, that has been subsequently published in a different journal. However, whatever organization sort of oversees the International Journal of Antimicrobial Agents, subsequently made a statement that this manuscript wasn't up to their usual standards. I don't really know what that means. But as a consequence, there is a lot of concern about this finding. It's generated a huge amount of interest. It's generated a whole lot of studies. And if it is true, it's incredibly exciting. But there are other larger studies done by different groups that have not had similar kinds of findings in terms of the antiviral effect of hydroxychloroquine and azithromycin.
Dr. Collier, can I ask a quick question?
Of course.
This is Brian Coppage. You might remember me from 20 years ago at Seattle Treatment Education Project, STEP. We did HIV.
Keep going.
Hi again. So on this study, one of the questions I have is there wasn't a control arm. Is that true?
Well, there was a control arm. That's the black line.
Right.
But at least in the original description, those controls were people at different hospitals than the ones that got the hydroxychloroquine or the azithromycin. So how similar they are to and what other treatments is really sort of a black box and not well specified in this particular article or the follow-up article that was done.
Do you think if these people would have not received treatment at all, that they would have had a chance clinically to end up resolving the COVID-19 on their own?
I mean, as I said, at least 80% of people tend to. So that's the thing that's so hard about uncontrolled data, is to know, first of all, how similar are these people really similar? Because if they're not similar, then if you compare apples to oranges, it's like meaningless. Which brings me to the need for a randomized study that really can then allocate people who are similar to groups and treat one and not treat another. So this particular study design was just really poor. That's my...
And this is Lori Sila.
Hi, Lori. How are you?
Good. Isn't there some more recent data that's come out showing that it's really not making much of a difference, and in fact, there's with the underlying toxicity for some people that they're now.
There are larger studies, but all of them have had challenges, and even so, there was a large VA study published 3 days ago, maybe 4 days ago, that treated several hundred people that described the experience at the VA with, I think it was 278 people, but anyway, a large number. And some got chloroquine, and some got chloroquine and azithromycin, and some got none. But even though, and it looked as if the people who got chloroquine were probably sicker than the people who didn't get chloroquine or who got chloroquine and azithromycin. And in fact, chloroquine and azithromycin looked like it did better than chloroquine alone. And so how does that make sense? And they didn't seem to have as much toxicity as the people who got chloroquine alone. But it really was very difficult to interpret that data because it was not at all clear that the groups that it was fair to compare them, even though they used statistical methods to try and sort of match and account for the differences in the groups. It still was not at all definitive. There are other studies from China, one of about 150 people that suggested, and there's some that have suggested benefit, and then there are others that have suggested no benefit, but none of them are really definitive if you really dive into the details in terms of being able to say that this either does or doesn't have activity.
And I have a question. This is Matt Sharp from Berkeley. Hi there. Thanks for a great presentation. I just wanted to make a comment about the treatment trials are really great right now with COVID. I worry, though, that we're going to get into this sort of, needle in the haystack issue with so many trials that are not really developed very well or designed very well. And we're going to get sort of ambiguous answers. And that's my opinion.
No, I completely agree with you. I think that's where we are right now.
But
if you add up all the people who have been in.
Right. But instead of that, what I would love to see is a narrowing or at least a focus on vaccine trials. I mean, that seems to be really where we can make a big difference.
Well, I think we need both. I personally feel like we need both because we clearly need prevention. But I think with all the people who have gotten this disease, it's also important to have effective treatment. So I think, and I don't think one excludes the other in the same way that HIV, there is people who are interested in treatment, there are people who are interested in vaccines, and those are proceeding in parallel along with the cure initiative.
And can I add also, I think one of the big motivations for those early trials that were kind of uncontrolled or poorly designed was not necessarily to prove that the drug works, but to provide a vehicle for getting something that potentially could be effective treatment to people really early. And so I think, one of the things that we at the University of Washington had done before the trials that Anne and I will talk about are able to open was provide these treatments to people thinking that they probably were safe and may or may not work, just to get them to people. Because it's an emergency situation. And so I think a lot of these studies that are kind of what we call a cohort study, meaning that everybody just sort of gets the drug and then you see how they do, was probably the aim number one, and aim number two was to collect the data. And so, what we hope to be able to do is not only answer the question to be able to provide people treatment who are sick, but to try to provide access to people in a really expeditious fashion, in the case that we're actually able to treat, to provide benefit to people before anything is FDA approved. Well, and to be able to get it FDA approved.
Yeah, I totally hear your point, and I agree with that as well. I mean, I do think treatment's important. I just worry that a lot's going to be confused along the way, and I just wish there was a way of sort of focusing the effort to get a really good trial done in the meantime. I mean, believe me, I know about getting into trials for access for therapy, but for HIV, obviously. But anyway, I just wanted to comment.
Well, we didn't plant you there, but we're going to talk about if people are willing to stick with us because we're taking longer time. We're going to talk about 3 what we think are really good trials that will be definitive if they are successful in enrolling the number of people that they are planned to enroll.
I can't wait. Thank you.
Next slide. So the one thing I wanted to mention is that because of the increasing concern from uncontrolled studies or small studies, the FDA did do an alert last week that suggested that chloroquine and hydroxychloroquine should be used for COVID-19 only where patients can be appropriately monitored in the hospital, as required by this emergency use authorization that I mentioned, or are enrolled in a clinical trial where presumably there will be safety issues that have been addressed in the planning of the study. And so that whether that is enough to avoid some of the drama that occurred when a certain person suggested that hydroxychloroquine was a great treatment or not is, I don't know. But right now, I think if anything, there's more anti-hydroxychloroquine than there is pro. So, which is another issue for trying to determine whether it's useful or not. Next slide. Oh my, I don't know what, There is definitely some electronic something going on because I didn't do that to this slide. But so the AIDS clinical trials group is doing a randomized double-blind placebo-controlled study. So, and I want someone to define that for me because I'm tired of talking. that is going to evaluate the efficacy of hydroxychloroquine and azithromycin in outpatients to prevent hospitalization or death in people who have COVID-19. So would someone like to chat or speak up about what a randomized double-blind placebo-controlled trial is?
Hi, this is Orbit Clanton. I am the ACTD community chair for the global CAB. And I was wondering if you were going to talk about 5395, which is supposed to start May the 1st, which is Friday. And what it will be, randomized, double-blinded, placebo-controlled, basically 2 arms. They will be enrolling approximately 2,000 participants, hopefully. Half will get the drug and half will get a placebo. Short version.
Right. So the double-blind means, so the randomized means that people don't choose what they get. Yeah. If they agree to be in the study, it'll be like flipping a coin. Half will get the active treatment. And because there is no current active treatment, it's ethical to give a placebo, which is basically fake pills. Double-blind means that neither the people entering the study or the staff doing the research will know who's getting active drug and who's not. So that's what the randomized double-blind placebo-controlled means. And it's not yet open for enrollment. It underwent some changes after the first version of the protocol was planned, and this has all been planned very rapidly within the last several weeks. It was due to open May 1st under the first version, and there is now already a second version that has now been approved by the FDA. And whether it opens late this week or early next week, it's still on an incredibly fast timeline, but not fast enough for me. I told them when they initially described the study and asked how many people we could enroll, I said, well, if it's open by mid-April, we could enroll a lot of people. If it's not open till early May, not very many. But that just reflects the data that Rachel showed you in terms of this decrease in the epidemic in the area I'm in. It is a national study, and so unfortunately there are probably areas in the country that will be able to enroll lots of patients. Next slide. And as you've heard, the treatment is hydroxychloroquine. The dose has been very carefully negotiated with the FDA to be a dose that is similar to that which is used in outpatients for prolonged periods of time. So it's for 6 days of treatment with a boosting dose on the first day, plus azithromycin, 500 milligrams the first day, and then 250 milligrams. And if anyone's heard of a, quote, a Z-Pack, that is actually the dosing for the Z-Pack. It's a phase 2B, meaning that it is it's sort of midway in the development of, so there have been small studies looking at this compound. So the study itself will be 7 days of treatment total plus 23 weeks of follow-up. And as you've already heard, the sample size is 2,000 with 1,000 in each arm. A subset of the participants will have additional sampling over and above what everybody else in the study is being asked to do. Next slide. And the individuals who are going to be sought for this study are adults with symptomatic COVID-19 who have had a confirmed RNA test for the virus within 96 hours of when they take the first dose of study medicines. So it's a very different kind of protocol to many of the protocols that I have done in my life, in that we're going to be looking for people who've just gotten diagnosed with COVID-19. People need to have either cough, fever, or shortness of breath. Those are all self-reported. They need to be over 18, and they need to agree not to obtain either of these study medicines outside of the study and to not participate in another treatment or prevention study. And that's really a safety issue as well as trying to make sure the data are interpretable. Next slide.
Anne, can I ask a question before we go to the next slide?
Of course.
So people have it's like 4 days, like, so they get their test, they're confirmed COVID, and they would have then 4 days from that.
No, they have 4 days from the time they had their test to need to be in the study and have taken this dose of study medicines.
Okay.
So testing availability has been a big issue, and testing turnaround time is a big issue. We at the University of Washington are incredibly fortunate. The current turnaround time for COVID-19 tests is 5.6 hours.
Wow.
Initially, it was a few days. We are just incredibly fortunate. That's not true around the country. There are still places, unfortunately, that don't have enough tests, or where turnaround time may be 1 or 2 days, which will be even more challenging for those sites to identify people, get them hooked in with the study team. But the screening and enrollment of the study can occur on the same day. So if someone hears about the study, is eligible and interested, then sites are going to be doing things to help them get in the study that day.
Great.
Next slide. Exclusions, this is not all of them, but they give a flavor of what is trying to be done. So if somebody comes in, screens for the study, or doesn't come in, is being talked to on the phone, and needs to be hospitalized, then they are excluded because that is the endpoint of the study, and they would be encouraged to be linked. They will be linked to care and encouraged to be hospitalized. There is a long series of exclusions for safety reasons, dealing with cardiac issues, ventricular arrhythmia, something called the long QT, if either someone has that or their family member has that. People who've had ischemic heart disease, so a heart attack, or have structural heart disease. If they have a history of low potassium or low magnesium, or are taking those supplements, because that would increase the potential for a problem with arrhythmias. People who have a history of serious kidney disease, if they've taken drugs that have anti-SARS-CoV-2 activity, drugs that are known to prolong QT, and I just picked out the one that was the most commonly in use that you guys might have heard of, called citalopram, which is known to do this. And then there's some prohibited medicines that are also more likely to potentially cause problems with hydroxychloroquine or azithromycin. And they include methadone, Benadryl, many seizure medicines, and certain kinds of diuretics, because they can result in low potassium, which would potentially increase the cardiac toxicity. So the study team has tried to enroll outpatients, but do it safely by having this bunch of exclusions related to things that were more likely to have them result in cardiac toxicity with hydroxychloroquine. Next slide.
Anne, could I ask you another question? I don't see HIV as a qualification or a disqualification here.
Nope. People with HIV who are unfortunate enough to get COVID can enroll. You don't have to have HIV to be in the study, but you can certainly be in the study as long as you meet the other entry criteria.
Great.
So the evaluation plan that most of the participants in this 2,000 person study will have all their visits by telephone. They are, if they want to, they can have an optional in-person visit at day 20. There will be 7 visits over the first 20 days and then a visit at week 12 and 24. And by visit, I mean phone call. Participants will be asked to complete a daily study diary about taking the study meds while they're taking the meds and about their symptoms. And they have to confirm that they took the first dose of study meds. And that can be them telling them or having a video or a FaceTime or a telemedicine visit, or in the subset that will be seen in person, it might be actually at their first visit. And then individuals will get compensation at day 20 after they return the study diary. Next slide. 200 of the individuals who enter the study are going to be asked to be an intensive sampling subset. We hope that we'll have 10 of those people locally. They will be asked to have in-person visits at entry on day 6 and day 20, plus the other phone visits. And at these in-person visits, they'll have a blood draw. They'll be asked to self-collect a nasal swab and then have the staff collect a nasopharyngeal swab. And they will be provided additional compensation. Next slide. And because of the infectiousness of COVID-19 and our desire to protect other patients who come to Harborview as well as the staff, we can't do the in-person visits at the UW-ACTU where we usually do visits. So they will be done in this newly created clinic at Harborview called the Respiratory Plus Clinic, which is in the entrance to which is in this tent at the back or front of the hospital, depending on what you think is back and front. And so it has a special entrance and air that is cut off from the rest of the hospital. And these other pictures are just a pass-through where samples can get passed through. The staff won't be able to go into the clinic without appropriate personal protective equipment. So there's a number of things that are different than usual. Next slide. And I think that's the last one of this series. And I think it is now time to turn it over to Rachel, who's going to talk about 2 inpatient studies that are being done in collaboration with the ACTG.
All right, thank you.
Before you do that, Anne, I've got one question. Do you know if they're going to be able to do any kind of, with that sample size, any kind of sub-analysis by age or disease severity or particular underlying conditions to see?
Yes, actually, that's a great question, Lori. The study, in the interest of time, since I'm already way over time, the study enrollment is going to be stratified by individuals who have no underlying conditions and individuals who have specified underlying conditions. So the study is going to be able to look specifically at, is the treatment effective overall as well as in these subgroups. It is also going to have specific objectives about looking at women and minorities, racial and ethnic minorities who unfortunately appear to be more likely to get COVID. And so it will be able to to provide data specifically about if this is effective. Is it effective across the populations, or is it more effective in some populations than others? So it's designed to answer that question as well as the does it work question. The other thing that I should say is the data are going to be reviewed weekly by a data safety monitoring group. in order to make sure that if there is any kind of toxicity signal, that it is recognized and that the study does not continue if there is a reason that we would be putting participants at risk by being in this study. But it should provide an answer. If it can be recruited, it should provide a very definitive answer about this treatment that we really desperately need an answer for. Okay, take it away, Rachel.
Great. So the two studies that we'll be conducting locally on inpatients are also beginning sort of an unprecedented naming scheme for us. So you'll see that these two studies are C5396 and C5399. C is, I actually don't know if it's for COVID or for collaborative, but the idea is that these are not ACTG native studies. They are both sponsored by Novartis. And then you all may have heard of this sort of public-private partnership that was announced with the NIH and with 15 pharmaceutical companies. They haven't really announced more specifics about this other than that, but this is one of those examples in which NIAID, so the National Institute for Allergy and Infectious Disease, which is who funds the ACTG, sort of did a matchmaking essentially between, as Anne mentioned at the beginning, our network and Novartis. So Novartis is the sponsor for these trials, is funding them, is providing the medication. But there are three of us from the National ACTG group, and I'm one of them that is part of the national study team to make sure that it's being done with scientific rigor as well. So this study is called HAT as opposed to HAS, which was the outpatient study, so HAT COVID. It will have 444 participants ideally, 20 of which we are hoping to recruit locally. It will be a 3-arm study, double-blind, placebo-controlled study with 1:1:1 randomization, meaning equal parts will be placed on each arm with a flip of, in this case, a 3-sided coin, metaphorically. The first arm will get hydroxychloroquine plus a placebo that looks like azithromycin. The second arm will get hydroxychloroquine and azithromycin, which I've misspelled. And the third arm will get 2 placebos that look like both of those active drugs. Next slide. So this is just a little study schema. Again, similar to the outpatient study, there will be 4 days from the test before participants can be referred to the study and screened and consented and enrolled. We think that we'll be able to do this much quicker because most patients will be tested in the emergency department or on admission to the hospital. And then we will be consenting and enrolling these patients who are in the hospital because they're sick. Again, the 3 arms, and I'll go through the treatments a little bit more on the next slide. The maximum duration of treatment is 10 days. And we're looking for a primary endpoint, which is the number of patients that need to be admitted to the intensive care unit and be put on a ventilator for additional breathing support, or who pass away and within the first 15 days. And then there will be additional sort of safety follow-up data collected through day 40 when we hope that most patients will be home by then. Next slide, please. So this is just a little schematic of how the dosages will be given. So in the first arm, this is actually higher dose hydroxychloroquine than the outpatient study. Again, we'll be using more intensive monitoring, which is part of why we've chosen this higher dose. So patients will get 600 milligrams of hydroxychloroquine or matched placebo, and the active versus the placebo is sort of denoted by whether it's blue or whether it's clear. So 3 tablets on the first day, followed shortly thereafter by the 500 milligram dose of the azithromycin or placebo, and then on the subsequent day, people will be getting 600 milligrams of hydroxychloroquine as opposed to 400 milligrams in 5395, and then also stepping down to 1 azithromycin tablet per day, just as in the outpatient study. This treatment will be proceeding through day 10 for the hydroxychloroquine and through day 5 for the azithromycin. Next, please. So eligibility criteria is really very similar, other than that participants will be hospitalized. So we're looking for any adults who have a positive COVID test from any respiratory sample, who are hospitalized or being admitted through the emergency department. Unlike the outpatient study, and despite our best efforts, we were not able to allow pregnant or lactating women on the study as we had hoped to. We are including people that have various forms of immunodeficiency, so including people living with HIV and people who've received an organ transplant or have underlying cancer are also allowed on the study. Creatinine clearance is kidney function, so people have to have a relatively intact kidney function. About stage 2 of chronic kidney disease is all right, or normal kidney function. And then QTc is an electrical signal, is an interval on the electrocardiogram, and Anne mentioned that about safety monitoring. So essentially we'll be following electrocardiograms very closely during this study, and in order to be randomized and enrolled for the study, participants have to have a very normal EKG to prevent any cardiac toxicity due to the medications. Next, please. So safety assessments for the study will be very key. Again, we're even prior to the results coming out of Brazil or other places, we've been really verifying that this study will be performed in a way that keeps our participants safe. And this includes very specifically that people will be getting EKGs before they enter the study, and immediately after getting the loading dose of hydroxychloroquine, and then again the next day, and then again 2 days later, and then several days after that, as well as frequent laboratory evaluations. This is actually going to prove to be quite a trick, because if you think about it, these are all things that require interacting physically with a patient. And as a clinical trials unit, we're used to having our study staff do all of these things. If anybody's participated in a clinical trial, you yourself would see the study doctor and have them take your vital signs and listen to your heart and draw your blood and all of these other things. The difference in this study is that in order to use less protective equipment in the hospital, not to use their regular supply, and to protect study staff, all of the study procedures will actually be performed by the usually internal medicine physician or critical care physician taking care of these patients, and by the bedside nurse. So we're going to be partnering with them very closely to make sure that this works. And again, really the main reason for doing that is to make sure that we're not draining resources from clinical care while we're in a resource-limited environment, and not exposing extra people to infection. So this was done very successfully for the remdesivir study that just completed enrollment here at UW, and we're using a lot of the knowledge that was gained from how they were able to do this, including consenting on tablets, or people's personal phones, and wiping down electronic equipment, and having very, very rigorous infection prevention standards. There are no paper consents, for example. So a lot of the sort of traditional clinical trials methods of doing things have been thrown out the window, and we're using really kind of some new innovative ways of accomplishing this to make sure that patients are being safe, that we're collecting their data. Informed consent is still happening. It's happening via an online tool that's being done with potentially a study person on the phone, going over questions with them, and the bedside nurse in the room. So again, a lot of workarounds in order to make this possible in an infection prevention environment.
Rachel,
Yes.
Do you think that, I mean, it's great to hear that they're changing finally informed consent practices and seem to, a new paradigm. Do you think this may stick around after this crisis? I mean, I think that would make a lot more of the informed consent practices more convenient for participants if we could continue to have tablets and non-paper sorts of sources.
Yeah, I mean, I really hope so. It's something that we have been talking a lot about, and one of the things that, as I sit on the HIVMA board of directors, and one of the things that we've really been talking about is sort of creating a push for national policy that uses some of these innovations, like the fact that we're all doing telemedicine now. Well, not everybody has access to telemedicine, but everybody who's right here on this CAB meeting is here on their tablet or their phone or their laptop. So wouldn't it be great and convenient if you could see your doctor that way in the future? And previously, a lot of insurances didn't reimburse for that, and UW wasn't set up very well to do that. Well, now we are, so let's not take it away when this is over. And so, yeah, it's my hope that some of these sort of innovative research practices can stick as well. I have to say the content of the informed consent is just as long and boring as ever. It's still 1 million pages long. Right. So that's not any better, but yes, the ability to do it on a tablet. I think the other thing that is really potentially helpful here is that, these are patients who are sick, and a lot of whom may have advanced age and might not feel comfortable signing an informed consent in navigating that in the hospital. So there are additional options where the patient may give assent, meaning they will agree to, in general, to the study, but not legally so, and defer the actual consent to maybe their adult child or brother or sister or partner or somebody like that who's at home and is not at the hospital because visitors aren't allowed at the hospital right now. So it allows the ability to send the informed consent via email to somebody's partner or adult child and say, why don't you read through this, have a phone conversation with the patient, and the patient can say, okay, I agree in general. Well, what do you think, Mom? Okay, sounds good. And then the person's proxy can actually sign the informed consent for them.
Wow.
So that allows for a little bit of sort of extra support and team decision making, which I think is great because, people who are really sick might not feel comfortable making these decisions on their own.
Right.
Rachel, I think it might be a useful future topic to talk about some of this, and I hope that in the process you have some way to evaluate and document the evaluation of some of this informed consent. Because we're also talking, not only are some of the patients elderly, some of them have distrust because of race, some of the providers are in situations where they have a different level of fatigue than they might in a normal research situation. And there are lots of things we could talk about around this, but I don't think we need another topic for tonight.
No.
Yeah, I think your point is very well taken, and I do not think that we are collecting that for this study, but I'm sure somebody is, and if not, I will put that to the UW research group and see if somebody's doing sort of an acceptability study about this. I think, as far as I know from the remdesivir study, and we're following their exact protocol, which is actually IRB approved for how to do this, and is actually been taken up by NIAID, so it's being used nationally, and we gave our consent procedures to Novartis that were developed at UW and are now being used for the whole study. And it seems as though people really like it because it gives so much flexibility for how to do the consent and flexibility in who to involve to help have shared decision making. So I'm hoping somebody is collecting that formal data.
Next slide.
Next slide, please. Okay, so risks and benefits. I think Anne covered a lot of this already, so I'll go through this quickly. So we think that that hydroxychloroquine has some antiviral properties and may also modulate the immune system in a way that's beneficial in preventing the cytokine storm. We think that that's probably the predominant way that azithromycin works as well, although it may have create some changes on the inside of the cell that make it less favorable for viruses to reproduce there as well. we know that there are toxicities associated with this treatment, but we will be mitigating that risk by really, having very intense monitoring and very close follow-up of these patients. Again, everybody will be in the hospital. Everybody will be getting a physical exam every day by their primary doctors and monitoring their oxygen continuously, et cetera. So we feel very comfortable with the safety profile and from this standpoint. One of the other well-known toxicities of hydroxychloroquine is to the eye. And that's really, again, seen in people who take this drug over years and years for lupus mainly. And so we do not think that toxicity is going to occur with such short-term administration. And we definitely don't see it when it's prescribed for malaria, for example. Next. Okay, any questions about HAT COVID before I go on to Rux COVID? Checking the chat, it sounds like people were bringing up distrust because of racism, not because of race, and to point out the barriers to participation. So absolutely, this is definitely a big issue. And, one of the things that I would add as an additional barrier in recruiting inpatient studies is, and rolling them out so quickly, is having the availability for consents in multiple languages. And at this point, we're planning on having consents in Spanish, but we may not be able to get consents in other languages quickly, so we may not be able to enroll people who do not speak English well enough to do a consent in another language, although we are seeking IRB approval, I believe, for a short form consent that can be done via an interpreter by the phone, and then a short form that's signed. A question about participants using over-the-counter loperamide to treat diarrhea based on the FDA warning about QT elongation and taking higher doses. So I think all of the prohibited medications are very well delineated for the outpatient study. Okay, Anne's got that question already. So that is excluded. And then for the inpatient study, nobody will be receiving anything that's not prescribed by a physician because they will be in the hospital. Okay, anything else, or I will move on to Rux. Okay, so Rux COVID is a drug probably that very few people, including a lot of physicians, are not familiar with. It's called ruxolitinib, which is why we call it Rux, because nobody wants to say ruxolitinib all day. It is a JAK inhibitor. So JAK is a molecule, it's a tyrosine kinase, which is sort of an activating molecule that works in a lot of different pathways, but it works in a lot of immune cells that is part of sort of the cell signaling pathway that helps activate different immune functions. So JAK inhibitors, the main purpose of using them and what they've been FDA approved for is to try to specifically inhibit different parts of the immune system. And ruxolitinib is FDA approved for 3 conditions, and all of these conditions are ones in which the immune system is sort of hyperproliferating. So various cell lines are producing too many cells. So the first condition is called polycythemia vera. So that's a problem where the bone marrow is producing too many red cells. Graft versus host disease after a hematopoietic cell transplant. So that's when somebody has a bone marrow transplant and the bone marrow is actually then attacking the host's body, like the skin or GI tract. And so they need an agent to sort of calm down that immune response of the new immune system against the host. And myelofibrosis, which is a similar kind of proliferative condition of white cells that actually ends up causing sort of scarring and problems in the bone marrow, where the bone marrow then it sort of becomes dysfunctional and isn't producing the correct kind of immune cells. So those are all of the conditions that JAK inhibitors are currently approved for. And so you might sort of ask, well, what's the logical jump? Why are we trying to use something like this for COVID? Well, Anne, at the beginning of the talk, laid out some of those really nice slides about cytokine storm, where we think that, obviously this is true in any infection, but it's really not the virus doing so much of the damage, that it's the immune system's response to the virus that's causing the damage. So in this case, that there's this something about this virus, and we don't really know why, but this is probably the key to why SARS-CoV-2 is so much more damaging than the kind of routine coronaviruses that cause, snuffles, is that, or sniffles, I should say. Snuffles is syphilis. So that, the reason why this doesn't just cause the sniffles is there's something different about this virus that really just enrages the immune system and causes a very robust response that can make people very sick and damage their lungs to the point where they can't breathe on their own, or sometimes even with the help of the ventilator. So this drug is not really proposed to have any antiviral activities. It's really proposed to try to work against this abnormal immune response, which is causing people to become sicker. Next slide. So here's just a little bit of the definition. So JAK is a Janus kinase. And there are some kind of early studies and studies for other conditions in which the inhibition of this JAK-STAT immune pathway can prevent cytokine release syndrome. So people have actually been using this medication recently. I don't know if people are familiar with the concept of CAR T cells, or these chimeric antigen receptor cells that have been recently used to combat leukemia and lymphoma, and are being tested as a potential mechanism for HIV cure as well. So sometimes when people get these immune cells to try to target their tumor, there's a really terrible cytokine release syndrome that can be life-threatening, and ruxolitinib has been used successfully for that. And then there are a couple of other rare immune activation syndromes, like something called HLH, which is also sort of an inappropriate activation of the immune system. And there's sort of early data that ruxolitinib can be helpful for that. There's also really good data from animals that shows that when this medication is administered, for example, in mice, it reduces inflammation in the airways. And if you take a mouse and you give them bacterial toxins that usually produce a really severe inflammatory response in the lungs, sort of as a model for ARDS, which is this respiratory distress pattern that we're seeing in COVID. So you can sort of manufacture a similar response to ARDS by giving mice bacterial toxins, and then they can apply this medication and it decreases that lung damage. So that's really the rationale for trying this medication, and specifically trying this medication in sick, hospitalized people to prevent them from becoming sicker. Next slide. Okay, so the goals of RUX-COVID is to evaluate whether RUX can prevent progression of COVID-19 pneumonia to intubation, meaning needing a ventilator, or death. And the secondary goals are also to evaluate the safety, because again, this is a drug that's felt to be pretty safe, and thousands of people have taken it for these hematologic problems, but it hasn't really been applied in a population like this, so we really need to document the safety. And the third goal is to look at whether it improves changes or causes changes in inflammatory markers. So people will be having inflammatory markers, as Anne mentioned, some of these, CRP and D-dimer and different cytokines and chemokines measured at baseline and then followed over time to see whether RUX can prevent the cytokine release syndrome. Next. So eligibility criteria, this is actually an international study that's being conducted in several places in Europe, as I mentioned, in addition to the US. Other sites are including teens in the study, anybody greater than 12, and part of that is sort of due to the age of consent in different studies. We've chosen to only include adults age 18 and older, and that's mainly a logistical reason that we're recruiting at the University of Washington Medical Center and Northwest campus, and we don't have pediatric patients there. So unless we were enrolling at Children's Hospital, we'd be unlikely to be able to enroll teens. Similarly, patients who are hospitalized have had a positive COVID test from any respiratory sample. And these patients also need to meet criteria for having pneumonia in addition to just being hospitalized, which frankly is pretty much everybody who's being admitted to the hospital with COVID. So low oxygenation or increased work of breathing. P to F is sort of how much oxygen is being given versus how much oxygen is detected in the blood. And so that's a measure that we use for people who are really sick. So this is essentially anybody who really has evidence of impaired ability to get oxygen in. We are recruiting slightly sicker patients as well, so people who are in the ICU but have not yet needed a ventilator. Because this drug is immunosuppressive, we are enrolling people who have autoimmune disorders, or including people living with HIV, but not people who are receiving medical immunosuppression, meaning chemotherapy or anti-rejection drugs after transplant. And then for safety reasons, anybody who has low white cells or platelets will also be excluded, because this drug, by intention, by impairing the immune system, may decrease those levels of those cell lines. Next. Okay. So this is a very simple study design. Patients will be screened over 2 days on arriving to the hospital, offered informed consent, and anybody who accepts and meets the eligibility criteria will be randomized to receive ruxolitinib. It's an oral medication. It's a tablet that's given twice daily versus a matching placebo twice daily. It will be given for a study course of 14 days. And then the clinician, both the treating clinician and the study clinician, have the option of providing an additional 14 days if the person is felt to be not improving, and in the opinion of that physician, they wish to proceed in offering a longer course, and of course if the patient agrees. So anybody who would be discharged from the hospital within 14 days would not be getting an extension of this medication. It's my suspicion is that we will mostly be giving 14 days. Next. So safety issues, I already touched on several of them. So because we're giving something that's an immunosuppressant, it has the risk of lowering white cells and platelets specifically. It can cause anemia or low red cells, but it tends not to do that as much, which I think is really interesting, because one of the primary uses for it is for polycythemia vera, which is having too many red cells. So I think it successfully lowers red cells sometimes, but not all the time. Ruxolitinib has shown to increase risk of some infections. The ones that have most commonly been noticed in these big randomized trials that were the original studies that got ruxolitinib approval were shingles and reactivation of hepatitis B or tuberculosis for people who already had those infections. Again, most patients that are taking ruxolitinib for something like polycythemia or myelofibrosis are taking this medication for a minimum of 6 months, if not a year or 2 years. And so it's not surprising that those patients who actually have underlying immunosuppression from that condition as well are likely to develop shingles or other infections. Again, we're offering this medication for 2 to 4 weeks, and so we think that the risk of other infections is probably pretty low. There's some sort of general common side effects like headache and nausea that occur with a lot of different treatments. And then people have experienced bruising or bleeding if the platelet counts get too low, which is why we'll be monitoring that actually much more frequently than is recommended for outpatients receiving this medication. Next. Okay, so again, when people receive ruxolitinib as part of standard of care for an underlying hematologic problem, it's recommended to monitor the blood counts every 2 to 4 weeks. Because we are conducting a study and we have patients who are acutely ill and may have, changing clinical status day by day in the hospital, we will be monitoring blood counts every other day. And if patients are discharged before day 15, they will actually come in to the same respiratory clinic that Anne showed in the picture and have their vital signs taken and have blood counts taken and additional tests for biomarkers, so some of those inflammation tests on day 15 and day 29. Anybody who's discharged home will actually get a phone call every single day just to check in on them and ask about symptoms and how they're doing. And we have a very careful sort of set of stopping rules to either reduce the dose of the medication or stop it completely if people develop low blood counts. Next. So this is just a little bit of a wrap-up slide that talks about other kind of research things that we're doing to coordinate amongst other COVID studies. Before we kind of get to the end of this time, are there any questions specifically about Rux?
Has there been any thought of doing any kind of a crossover design if people are not improving in whichever arm they're in?
That's a good question. We don't think that it would be appropriate for this type of study. They're great. A crossover design works really well when people have sort of a stable condition that's not expected to change day by day. We think that it's most important to give an immunomodulator like this at the beginning of the illness or as close to the beginning of the illness as possible, because we really are trying to prevent people from starting to develop ARDS or to need a ventilator. Part of when I sort of said I didn't think that we would be giving many people an extension of the drug is that I think that if people have progressed to needing a ventilator and are sort of stably very sick, I don't think that based on how we know this medication could work, that those are the people who would benefit. So I think I would hesitate to say that somebody who didn't benefit from either the ruxolitinib or the placebo at the very beginning of their illness as they started to get sicker and sicker should be getting this medication 2 weeks into their illness. And again, actually, most people will already probably be a week into the illness by the time they get sick enough to come to the hospital, based on how we know that people sort of tend to have mild symptoms for several days and maybe even more than a week before they get sick enough with pneumonia. But it's a great question. I didn't help design this study, and I have been sort of questioning the benefit of that second period of the medication, and I honestly think that it's there to be able to continue providing the drug if the patient and provider were feeling as though it was providing benefit.
Thanks.
Okay. So, and Brian is asking, what is the standard of care mentioned? Okay. So standard of care is so for both HAT and Rux, the standard of care is all of the supportive care that's being given in the hospital. So oxygen, fluids, monitoring electrolytes. If people develop a clot, which is sort of, as Anne mentioned, this sort of new area of understanding about what happens with COVID, people will be offered therapy for that. In the HAT study, because it has an antiviral mechanism, we're suggesting that people not get any other medications together with it. That will change if something else becomes FDA approved, like if remdesivir became FDA approved, if it showed that it worked, and we thought that somebody was getting sicker while on that study, they'd be able to get it. That's also true for Rux, but Rux, because Rux is not thought to have antiviral effects, people are actually allowed to get any other medication that has antiviral properties, or or potentially even the convalescent serum. So we're asking that people not get investigational agents, because it's really, the goal of these studies is to understand if the treatments work. And if you mix together a bunch of things in a soup, it's hard to know if they work or not. But there are definitely clauses in both of these studies that if something were to become available as the standard of care, that would be able to get added into what people are receiving. That's a great question. Any others? Yeah, and I think the last kind of important thing to note, and Anne and I talked about this a little bit at the beginning, is that people who at the beginning of the outset of the epidemic in Washington State and elsewhere, people were sort of providers in the hospital specifically were offering patients a variety of things that were FDA approved for other conditions. Some of these immunomodulators that we use for cancer, hydroxychloroquine and azithromycin, lopinavir, ritonavir, and we're just kind of giving everybody everything because we wanted to, hope that something works for people who are very sick. But now that we have no data that those things actually are working, either because they have studies that shown that they haven't had a benefit, like lopinavir, ritonavir, or tocilizumab, which is another immunomodulator that doesn't have a lot of results out yet. What we're doing is we're sort of peeling back those experimental therapies that were being given outside of a study, and asking that people really just get the study treatment unless something else becomes available as the standard of care, in which case that could get added to all participants so that it would no longer be a true placebo arm, that everybody would be able to get the standard of care treatment layered on top of the study drug. Okay, so just again, a little bit of wrap up. We wanted to talk about kind of COVID research innovations that are happening at the UW. So in addition to the studies that we've discussed today, there's a critical care network that operates at many different academic institutions across the country and has researchers in the pulmonary and critical care fields here at the University of Washington, and that network is called PEDAL. And so similarly, they've been retasked with COVID research for the sort of similar mechanisms as us. They have some ongoing studies that are mostly enrolling at Harborview, and there may be other treatments that are coming along the line, including things that we didn't really talk about today so much, like convalescent plasma. So there are two different working groups that have been created. One is sort of a clinical and scientific oversight committee, which Anne sits on and chairs, and is really aimed at making sure that any of these sort of new, quick, rapid rollout research ideas really meet both scientific and ethical standards to be done at the university, even before they're sent to ethics committees. To just make sure that the studies are being really done rigorously, and that we don't fall into some of the pitfalls that we've talked about with the French study or the Brazilian studies, where they really didn't answer the questions. And then there's a second committee that I sit on that just talks about coordinating all of this research. So, obviously, if a research coordinator or 4 different research coordinators knocked on a patient's door and said, would you like option A or B or C or D? It would not only be very confusing to the patient, but I think would create an undue burden on them to try to make a decision in what's best for them in a timely fashion amongst a bunch of experimental treatments. And so we are working in a concerted way to make sure that the studies are not overburdening patients with decision-making, or with having too many procedures done, too many blood draws, too many consents, too many research coordinators knocking on their door. It sounds silly, but it could be true if we weren't careful. And in addition to making sure that there's sort of equitable distribution of these across different study sites, so that as many patients as possible who are mainly in the inpatient setting, as many people as possible are able to join a study and get the potential benefits of a study drug, as well as contribute to research. So we already touched on sort of the innovations that we're working on. Again, a lot of these studies have been planned starting from the middle of March or the beginning of April, and started from that moment, from the protocol writing to going through the FDA to, being funded and up and running by next week. So we're working really hard to not only make sure that these studies are, rigorous and ethical, will answer the questions that we need to answer, but are also sort of, changing the way that we do research, hopefully for the better, and hopefully with ways that might stick for future studies. So I think the next slide was just questions. Is that right, Michael?
Yep, that was it.
Perfect. Okay.
Yes, hi, this is Orbit. Great presentation. And I like what y'all are doing. I just wanted to remind you guys that, especially when we're looking at some of these different studies that are maybe done or being put together by pharmaceutical companies, because of the urgency of the COVID-19, it's been brought to our attention that a lot of times the community's input is actually not even being considered. So that some of the protocols are already in development, but I just wanted to say that the community still should look at them, especially if they're going to be using the ACTG apparatus to roll these out.
I think that's a very good point. Certainly the protocol, the outpatient protocol, which is a complete ACTG study, does have community representation, as I think you probably know, because it was used, although the mechanism has been accelerated, it has the same kind of study team that all of the ACTG studies have. The one piece that didn't happen because of the perceived need to do it so rapidly was indeed bringing an early draft of the protocol to the community advisory board, i.e. this meeting. So I fully acknowledge that didn't happen, and in fact sites didn't have a chance to comment either. So we're all in the lack of ability to comment, but the perceived urgency to get it open is why that team chose that strategy. Mm-hmm. And certainly, I think if there are comments that people have about specific protocols, I'm certainly willing, and I know Rachel is, to take them to the protocol teams. And the point about industry and being open to community input, I think probably really depends on the company. I mean, some companies are often very open for input and others aren't. And unfortunately, many of the people on this call know that all too well.
Yeah, I think it's been a really interesting position to be in, because I have to say, even as one of the protocol leads for the HAT study, we had a couple of ideas that team members felt strongly about academic researchers, and I think they were valid contributions and worth exploring. But the idea is that, we're already opening the study at the time that some of these studies that didn't provide the right kind of data are already providing their results. And so, people are saying, oh, great, you're doing this randomized study. Where are your results? Where are the results? Do you have them yet? And I said, well, we're enrolling our first patient next week. So some of the timelines, as Anne mentioned, are so tight that, you know, some of the things were even finalized. You know, I stand by the protocols. I think that, you know, they are scientifically sound, but they didn't have all of those opportunities because this is sort of a new type of research. It's totally different from what we are all used to, for sure. And then I would just say the other thing that's tricky about this is that the question, I think, and a lot of people have been bringing up as well in different forums, is sort of who is the community for these type of studies. We don't really have a group of survivors of COVID yet. We, at least in the United States, I think that people are starting to form these groups and talk about the collective trauma and of being a patient and being scared, especially not having, you know, loved ones in the hospital with you and having all of your doctors and nurses where you can't see their faces. And people have been talking a lot about sort of forming survivors groups and some of the things that the positive community has done over the years. But there isn't really a community or community board yet for these things. I think over time there will be, and I'm hoping that they will sort of follow suit and learn some of the lessons that have been learned through the years that I think many of the community members have taught us researchers. But it just isn't there yet.
I just want to thank everybody for staying for what was arguably a much longer presentation and much longer meeting than we had intended. But hopefully the fact that so many of you hung in there means that somebody got value out of it, and I appreciate it very much.
Yes, I do as well. I wanted to also just leave everyone with a little bit of information. You may not have heard, but HIV 2020 is going to be going virtual, and it's going to become free for everybody. So this is where community is reclaiming the global response, and I just wanted to put that bug in everyone's ear. They're going to have a series of virtual convenings that'll take place starting in June, and they're going to go through October, and it's all going to be free. So keep your ears to the ground and for more information about how you can join these efforts and the conversation. And I wanted to thank you all for really joining us today. I really appreciate each of you taking the time. Here's all of our emails. If you had any other further questions, you could send it to me or to Anne or to Rachel. And I wanted to say thank you for tuning in, and I wish you all a good night. Stay healthy, stay safe, stay at home. Thank you much.
Thanks, everybody.
Thank you all. Thank you, everybody, for participating. It was fantastic.
Yes, thank you.
Bye-bye.